All right, we are going to go ahead and get started. Thank you and welcome everyone. I want to thank you for joining us today for our second webinar. My name is Dana Heschmeyer, Specialist of Strategic Programs here at Intalere. Today, our second webinar in our series for recovery resources for ambulatory surgery centers is going to focus on infection prevention. Today, we are going to be hearing from Tracey Chadwell, Senior Director of Advisory Solutions, John Trotta, Director of Construction, Capital and Facility Services for Intalere, and John Goehle, who is the owner and COO of Ambulatory Healthcare Strategies, LLC. AHS is one of the nation's leading regulatory and financial consulting organizations for the ambulatory surgery center and office-based surgery industry. Mr. Goehle is also the creator of the ASC podcast with John Goehle, and you can find that podcast series at ascpodcast.com. All of our participants will be placed on mute during this presentation until the end when we will open it up for Q&A. If you do have a question during the presentation, my apologies, you will have a message chat box or a hand raise that you are able to submit a question during the presentation, or you can wait until the end during Q&A. You are also able to submit any questions to asc@intalere.com. This session is also being recorded and will be made available. Today, Tracey, John, and John will be sharing their expertise on infection control and best practices and awareness, including reopening and screening best practices, medical waste disposal, staff competencies. Then we will go into facility considerations, which will discuss some things such as OR turnover times, waiting room configurations, and technology. And then we will finish it up with patient, visitor, and vendor considerations and how those all play a key role in infection prevention. So let's go ahead and get started. So these days, we all have a heightened sense of awareness of ways to resume our daily activities as safely as possible by wearing masks, washing our hands, etc. Tracey, can you please begin with discussing some of the best practices surgery centers can implement in their daily activities that promote the use of standard precautions and CDC recommendations for their patients and staff?
Sure, Dana, thanks. When we're looking at reopening, one of the biggest things that comes to mind is screening patients and staff. And I know right now, and I think John can speak to some of this too about what he's seeing across the country, but they're looking at anywhere from 5 to 7 days about doing screening for COVID. I know here where I live in Tennessee, they're actually doing it 7 days because it's taking longer to get the test results back prior to procedure. So that's definitely something everyone needs to take into consideration and find out is what is an appropriate expectation in getting results turned around. Same thing with staff, and always having a plan. If something does happen, in eventuality that a patient turns up positive or staff does, what's the plan? What are you going to do? How are you going to take care of that? We need to be looking at cleaning, what we're doing now. And some of it's going to help if patients see this and see what you're doing because they're going to be watching. They're going to be watching very closely as to what your staff is doing. So frequently going out if there is a waiting area, and going out and wiping down, making sure that any areas where there are high touch surfaces, that those areas are being cleaned very frequently. The process should be standardized about what you're doing. We've had several discussions with people that recently, in healthcare settings are seeing where they're just not quite getting it, and they're using the same rag to wipe different surfaces, and different things are happening. And like I said, people are watching, and so the more consistent you can be in your practices, and the more education you can provide staff, especially housekeeping staff, janitorial staff that again may not have the extensive training to be able to do that. Turnover kits between procedures is really a good idea because it standardizes the process. helps everything be where it needs to be in one place, so it actually can make a difference. And they can even put in disposable sheets and those types of things. So depending on kind of any changes you're going to be making to your processes, anything that you can do, again, to promote the standardized practice so everyone gets in a habit of doing something, and then hopefully it'll just be muscle memory, when they go through to do it. Medical waste disposal, there's a lot of places that are spending a lot of extra money and dollars, which we can't afford at this time, looking at disposal of waste. And waste disposal from COVID patients is handled the same as it is for any other type of medical waste. If it's not saturated and just really contaminated by use, then it just was put in a regular type medical waste disposal. It does not need to be red bagged, and we're seeing that happen a lot. And again, that costs a lot of extra money to do that and to process that. And going back to the staff competencies, making sure that everyone is really familiar with the proper procedure for donning and doffing their protective equipment and what needs to be done. And that includes, like I said, housekeeping staff. What is the dry time? How long does something need to stay on a surface in order to kill the virus? So those are things that really need to have a lot of attention put to them and documentation put to them, so you can actually show that this stuff has been done, so that you have some form of comfort in that these processes are being carried out consistently and within what is the expectation and what is going to be most effective for performing your infection control practices.
Great, thank you for all that. John Goehle, do you have some thoughts you'd like to add to that?
Of course, I'm never at a lack for words.
And we appreciate that.
So let's, so many notes here. Let's just start with cleaning. One thing to make sure of is that your infection control coordinator, which every ASC has to have, first of all, make sure their training is up to date. A lot of our infection control coordinators were initially trained on ASC infection control, sometimes many years ago, and they don't always follow the requirement that they have ongoing training. So definitely as a surveyor, I'm going to be looking for documentation that not only did they have initial training, but during this COVID crisis, they've had specific training for ASCs and specific training for COVID-19. So any cleaning materials that you use, any cleaning supplies that you use need to be approved by the infection control coordinator, and of course you need to make sure that they're effective against coronavirus. Keep good logs of your cleaning. This is one thing I also see is that when we walk around and we see that the place is clean and everybody seems to be doing a good job, we don't necessarily have to have extensive logs, but nowadays you're going to have it, and keep those logs in a place that's readily available to surveyors as well as your staff. Consider preparing a book or putting a book together that is shared between you and your cleaning company if that cleaning company is not there during the day, and then use that as a log of communication back and forth between the cleaning company and yourself as to any issues that you identify. And every morning, again, if you're using cleaning companies that are in after hours, every morning have somebody assigned to go through and double check that all the cleaning was done. Also demonstrate ongoing training of the cleaning staff. So you're going to need to have some evidence that the cleaning staff has training in COVID-19 specifically. And if they're not getting that from the company that employed them, you're going to need to do that. And by the way, you still need to do, if you are hiring an outside company, you still have to demonstrate that you train them on cleaning of your facility specifically. Going back to screening, I know this actually pops up a couple times in this conference, but as Tracey indicated, some of the states are requiring you to do testing of the patients prior to surgery. New York State, for example, has a requirement of 5 days. That's up from 3 days. So one thing you need to be thinking about very carefully is what types of safeguards you're going to put in place if testing is not required, or even if testing is required. For example, if you are not doing testing on patients, or if you're not required to do testing on patients, and then you might need to consider the use of N95 masks and all the things that come with it. Tracey did a good job of, as always, explaining what's going on with training, and I cannot stress this enough. And she mentioned staff competencies too. We're going to want to see ongoing training, and this isn't just one and out training. You're going to have to show ongoing training of all of your staff. Keep them up to date, because as we know, things are changing every minute here, and we're learning new things. You're going to be using different types of cleaning materials probably throughout this process. So I want you to put together in your staff training book, and let's refer to that as an in-service book, demonstration of what was trained, when it was trained, who was part of that, and then demonstrate you're doing that probably on a weekly basis. Whatever is necessary. And with that, competencies, has some competencies that have been drawn up that are specific to COVID-19, as well as all the other competencies that you're going to be doing. And use these competencies, or use competencies also when you're training your staff. Let me see. And just one thing about screening patients beforehand is make sure you should have some kind of ongoing logs that you're maintaining for patients and family members and visitors that are coming in. And I think we talked about this last time. Really discourage vendors from coming into your facility during this time.
Thank you, John. I appreciate that. John Trotta, do you want to share anything? We're going to be talking with you next on the next question, but do you have anything you'd like to add on these best practices with physical barriers or signage? Or anything else for that matter?
Hi, Dana. Sorry about that.
Oh, thank you, John.
My unmute didn't want to work. Well, as you know, there's a lot of barriers coming out that can be configured for special needs or special areas within the workplace. Those barriers can be adjusted or taken down as needed. So we can avoid construction where we have to bring in people, and that's something we don't want to do at this point in time, or create dust and other inhibitants. Signage is very important in a hospital or a healthcare facility. Americans are creatures of habit, so we tend to want to gather closely. There's many different signage programs out there that can keep people in the proper space needed to allow social distancing. That should be done. Signage postings should be done, directing people to restrooms and to traffic flow. So that's something that should all be taken into consideration. I did want to piggyback a little bit on what John and Tracey said as well too about keeping your staff educated. There's some new pieces of equipment that may be coming into these facilities, like misters and extractors. So those folks should be trained on how to use them, and more importantly, how to keep those, clean and ready for the next time they're used. So that's pretty much about everything I have to say. I think Tracey and John really covered that very well.
Well, thank you. And stay off mute so we can go to the next question with you. Speaking of facility considerations, what are some things that our surgery centers need to incorporate in their daily facility operations and some best practices?
Okay, so let's start with the first one, which is OR turnover. So a common OR operates with its own separate humidity and what's called laminar airflow, which is just really air moving at the same speed and direction with minimal crossover air. And obviously, if we have crossover air, we're going to have like more of a hurricane situation than we are a smooth airstream. Air conditioning systems generally allow for about 25 air changes per hour in a standard OR. Now that we're working in a COVID environment, there has been some additions to operating room procedures that should be taken into consideration. So the first one would be to identify an appropriate operating room or procedural suite. Okay, and that location should be on the peripheral of the other suites, or should be in a remote area out of the traffic pattern if possible. keeping that area away from the other patients who are not infected with COVID. Once you have that location identified, then teams should prepare the room prior to the patient arrival. In addition to the usual preparation, should take any loose items on the shelves or any laminated signs down so that none of that is obstructing the OR once an operation is in process. So you want to try to limit the amount of movement as much as possible in that room once a procedure is being done. We talked about signage before, but here we want to post specified precautionary signs on the doors of the OR so that everyone knows that that is an OR room and that a procedure is taking place. Want to also ensure high quality of heat and moisture exchanging filter in that room so that you have an accommodating temperature while the procedure is being done. The next thing I wanted to talk about sort of falls between patient flow and what happens after an operating procedure is taken care of. Is done. We hear a lot about airborne infection isolation rooms, which is really just negative air pressure rooms. And the significance of a negative air pressure room is really to prevent infection from spreading room to room. So the airflow actually comes from outside the room into the room through a filter that leads to the outdoor or recirculation of air through what's called a HEPA filter, which is just a high efficiency filter. So in other words, you're really just operating in a vacuum. So we're hearing that a lot, that patients with COVID-19 should be put in this type of room to avoid the spread of the disease. That begs the question that is negative pressure required for COVID-19 patient treatment? And the answer is no. The CDC recommends to place COVID-19 patients in a single patient room and keep the door closed. They also recommend to limit transport and movement of the patient, house patients in the same room for the duration of their stay, and whenever possible, perform procedures on the patient in that particular room. So with that, I'm going to move just to patient flow. And like I said, these sort of tie in. So patient flow is an area where much can be done to mitigate the risk and spread of COVID-19 in a waiting room. Healthcare organizations that have multiple locations have chosen to designate certain offices solely for seeing patients with suspected COVID-19. Designating their offices to see the patient for ongoing chronic and acute COVID issues, this separation reduces the likelihood of patients spreading COVID-19 to others in that area. Let's go to the next one, equipment cleaning and covering. So high-touch equipment in the operating room should be wrapped with plastic covers, both over the surfaces and behind the equipment itself. Okay, these surfaces then afterwards can be wiped down with the proper cleaning agents, and then the plastic can then be removed and disposed of, protecting the equipment and getting rid of any contamination that occurred on the wrap. Let's go to waiting room configurations, and we touched a little bit about some things with signage on that previously. So, we want to have visual alerts placed, and I already mentioned designating what we'll call floor signs that keep people 6 feet away from each other when waiting in lines. We also want to set up the waiting room furniture in a fashion that promotes social distancing. So maybe have chairs or lounges 6 feet away from each other. I would have signage that specifies that as well too, just so people are aware of it. I would remove we should have all removal of self-serve beverage stations such as coffee or tea, so there's no handling of that. Cover public water fountains. Those should be draped with some kind of covering, and then signage should be put on those that they're out of use at this time. And then you want to reduce the crowding in waiting rooms. So you may want to have people who are not actually patients wait outside or wait in the car while the patients can sit down, again, practicing social distancing. And then finally, there's technology. And there's been a lot of technological equipment and products that have come forth. Some of them aren't as new as we think, but COVID-19 has brought them to the forefront. So we hear a lot about ultraviolet. There's what's called whole room disinfection systems, and I've actually seen these put on robotics. The hotel industry is using them, where they'll actually remotely have them go in a room, hit the room with the UV, and take a whole room in its entirety and sterilize it. So that's probably going to be coming into the healthcare market, if it hasn't already been utilized with some of the larger healthcare systems. There's ionizing air cleaners, and without getting too technical, ionizing air cleaners produce a negative positive ionization of particles. Those particles clump together and then are easily grabbed with air filters in the HVAC system and throughout the building. So those type of systems can actually be retrofitted to current HVAC systems. So that's something that you don't have to spend a lot of money to really have an ionization system. And then we're also seeing thermal sensing solutions, which are really heat sensitive cameras or devices that can detect heat, mostly surrounding folks who may have a temperature, which is definitely one of the signs of COVID-19. These cameras can be placed also in various areas or at entrances with a handheld unit to take people's temperature as they're coming in. So that's just a few of the things that we're seeing as far as technology goes. I'm sure we'll see some others coming forth. I had mentioned partitions before, and we're seeing a lot of our furniture system companies coming out with the movable partitions, with partitions to divide areas and protect areas where staff have to meet with patients. So that's it.
Great, thank you. John Goehle, you had said something on one of your earlier podcasts with Tracey and Brian from last week about waiting room configurations, and what John Trotta just said reminded me of that. And I just want to see if you could maybe shed or give us some more insight on having visitors of the patients wait in the car. With it being summer in some states, that might not be safe or very feasible. So you had touched on a few options of what maybe some of the facilities could do to help with that.
Yeah, and I think one of the first things you can do is not even run into this problem. We have a lot of centers, for example, we know the physicians will just say, hey, bring everybody in at the beginning of the day, and that way I'll just filter them through as I do the procedures. Well, that's not going to fly in the new world. And of course, doctors love doing that because they never want to be delayed because, they're running ahead of schedule. So I think this is a time to start really getting very careful about the timing of people coming through, minimize the number of people that are called in way ahead of time in your operation, and that will actually minimize the number of people that you actually have to deal with in the waiting room. To your point, or to, I guess, my point, if you're in a non-urban area, we have a lot of urban centers too. So let's start with non-urban. If you've got a place where you can kind of pitch a tent outside and put a big fan out there, well, you got to be careful, obviously, how the fan is aimed. But find a way to house people outside of your center if that can help you. If you have no choice but you have to put them inside, then you just block off as many chairs as necessary. Actually, if you can, remove them so that people are kept apart. I think what we talked about on the podcast is, look around your facility. Maybe you've got some unused rooms. Maybe all of your, a lot of your business office people are working from home now, and you might be able to repurpose some areas that they've been in. Obviously, make sure that there's no privacy issues, but repurpose rooms as necessary in order to maintain social distancing. Also in those waiting rooms, I guess it's kind of obvious, but no toys, no books, no magazines, unless you feel like cleaning all of them in between every single use. Anything that goes in there, there's some centers, for example, that put their privacy notices on a laminated sheet of paper or sheets of paper in the waiting area. Well, don't do that anymore. Anything that you give to them needs to be taken and removed. I know another way we used to do it is we would, hand somebody a privacy notice and they would say, "Oh, I don't need it," and then you would take it back. Well, if you give it to them, they take it, or you just throw it away. You just can't, take it back into your hands. Patient flow, again, very careful planning, I think will really help minimize the number of people that you have. If you're in an urban area, this gets very difficult because people are often dropped, even more so in an urban area where you don't have an option to put people into the cars. And to your point, Tracey, Dana, I agree. I'm not sure having people stay in their cars is going to work now. So just try as much as possible to use timing to decrease that volume. Moving back to OR turnover, a very controversial subject right now is some of the recommendations from SG&A and AORN. Interestingly, by the way, this is not from the CDC. So if you're looking to the CDC about this room turnover, it is not a recommendation of CDC. It is a recommendation of the AORN and SG&A that you increase the amount of time that you wait in between procedures to allow the additional air circulation to completely remove everything from the air. And it all depends upon how much airflow is occurring. We're finding a lot of pushback on this because the doctors don't want to wait that additional time. If you do decide to not take up the recommendations of SG&A and AORN and the other organizations there, you really need to document your reasoning. For example, one reason might be that all of your patients are being pre-screened for COVID-19 beforehand, so that the risk of somebody actually having it is minimal. But you need to document in your minutes that decision-making process. Your quality improvement minutes, your governing body minutes are going to be very long during this first half of during all of 2020, because there's going to be a lot of explanations in there, a lot of decision-making processes in there that are documented for future purposes. I did want to mention something that John mentioned, and I think it's because, John, you work in hospitals and surgery centers. You really shouldn't be doing patients in the surgery center that have COVID. 19, they should either be sent to the hospital if it's an urgent case, or they should be, that you should wait until they're no longer active. That being said, I just had a patient today in one of our centers that absolutely needs to be done surgery center, and they don't have an option to go into the hospital because it's an eye procedure and the hospital doesn't do those procedures anymore. And our recommendation to them was that they took, that they basically tried to have that patient be the only patient that's in the surgery center, that they're going to completely isolate that patient, do all the procedures, as John indicated, in one room, so that they minimize the amount of cleaning that needs to be done. But if you have a patient with COVID-19, it really is not appropriate. It's certainly not appropriate to be doing elective procedures on them, and probably shouldn't be done in an ambulatory surgery center unless there's absolutely no other option there. And lastly, when it comes to cleaning, I guess one thing I would add on to what John said is we're all pack rats. We often tend to keep equipment in the operating room just because we might need it sometime in the future, or because we have no place else to put it. Keep in mind, everything that's in that operating room is going to have to be cleaned between cases. And, covering it with plastic is great. It's what we should do, but that's yet another thing that you have to clean. So keep everything out of the operating room or the treatment rooms that absolutely don't need to be there. So it's time to clean house a little bit, and recognize that everything else that's left, you're going to have to be cleaning in between.
Thank you. Appreciate all that insight. Tracey, did you have anything to add?
Of course. And to tack on to what John D was just talking about with in regards to patient flow and even turnover time, looking at the types of procedures that are being performed and what is being required, if it's actually having any kind of aerosolization, so again, intubations and those types of things, that's going to determine the amount of time for the room turns or the air turns that would need to be required. That was what John was alluding to. But you're also seeing some new technology that's coming out, whether it be I've seen pictures of people putting masks kind of over the face while they're doing some of these procedures that could create it, or just there's even some kind of suction equipment that's being used to kind of almost put over the patient near the face to try and capture that. So you're seeing a lot of things coming out, or different techniques. I don't know if everybody has seen it, but like even they were showing pictures of people using either kind of like a dome piece of plastic over the patient's face while this stuff was being done to protect from that. So there's considerations that can be made if you're running into issues where, you know, you're having a problem with turnover time, or you're getting at there are other safeguards that can maybe be implemented to show, you know, that you're taking some precautions if you can't always adhere to the turnover times, if you're getting so much pushback in regards to that. So that kind of combines with the technology, and that you're seeing more and more of these types of things coming up to allow to, again, help mitigate some of the time that you're having between cases. So scheduling is incredibly important when you're looking at this. The other thing that I thought about from the waiting room issue is how we've seen urgent cares in the past where you can actually call to see how long the wait time is. So if we're looking at whether it be the ability to text patients or somehow communicate with them in another way where they can either check on, you know, when they should be coming, or you can send it to them when you know the case is about finished and this is when they can be coming, and that kind of thing. So even some of those may be some innovative ways to look at doing this, because like I said, we've been doing this with urgent care in a lot of urban areas where you're not sitting around in a waiting room in urgent care. You've kind of got a pre-designed slot, or at least you can call ahead, or they'll call you once they know how far out you are from the site. They can call you an appropriate time for you to get there. So again, it's a lot of thinking outside the box and finding different ways to do things that we really never thought about doing before to reduce the number of patients waiting and having the risk of transmitting any kind of a viral disease.
Thank you for that. And, you know, those are, you think about a lot of these things that are happening in other industries that, you know, it's kind of nice to see healthcare getting on a lot of those, jumping on a lot of those considerations as well. So thank you for that. So patient, visitor, and we needed to add vendor considerations on here for our next topic. John Goehle, I'd like you to share some of your expertise on how patient, visitor, and vendor expectations play a key role in infection prevention measures. I know we've talked a lot about this already, but you know, I don't think we can emphasize the importance of communicating to our patients and visitors, and especially vendors, during this entire surgical process. So if you could go ahead and share some of your insights.
Sure. And you know, in preparing for this, one of the things that struck me is that instead of thinking about this as an extra burden on our staff, I would look at it as a huge opportunity for us to show how we shine compared to anybody else. You know, so take that in consideration as we're talking about these things. This opportunity to communicate sounds like a burden, but it really is an opportunity for us to show how much we care, how many precautions we're taking for our patients, and then hopefully, you know, changing. I mean, I think ambulatory surgery centers have a very good image out there, but let's take it a step further and just show how much, you know, how we can really shine in a time like this. So, ongoing communication. I think most surgery centers do communicate with the patient prior to surgery in some way, but now you're going to have to communicate with them and explain to them all of those things, all of those precautions that you're taking to be safe. So communicate how you're going to treat the patient, how you're going to treat their family members. You know, how many family members are going to be allowed. We're running into the summertime, so they're going to want to bring all the kids with them. Well, you know, please don't do that. Otherwise, we're going to be babysitters also, and you know, tell them the expectations that we have of them when they come, and what they can expect from us when they come. Indicate to them what you'll do with regard to PPE, for them. In other words, are you going to give them a mask? Are you going to give the family members a mask when they come in? Run through all of the procedures that you'll do for cleaning. You don't have to be specific, of course, but explain that all of your staff are trained on an ongoing basis. You're up to date. You're using the most recent cleaning materials, et cetera. And one of the new expectations, which will become a standard of care, is that calling the patient afterwards. We know that generally in an ambulatory surgery center, we call them the day after or the first business day after the procedure and follow up. And now we really want to follow up a week or two later to find out post-surgery whether the patient was found to have COVID-19. And document that and be prepared for any ramifications of that for your center and for all the patients that were there. I should also mention you should be maintaining a thorough list of everybody in the surgery center on any given day. So you should have a log at some point of all of the employees, all of the vendors, all of who hopefully are very minimal, and all of the patients and I say family members that are there. This is going to be the new standard of care. And I guess the question that's being asked to me a lot is how long are we going to be doing this? It's going to be done in July. Until somebody tells us not to. One of my concerns always is whenever we add, standards like this, that somebody inevitably forgets to stop them at some point. So I hope this will eventually end, but it certainly isn't something in the near term. Use this as a marketing tool. Put things on your website to explain what you're using, what you're doing, the communication that you're going to have with the patient so that they can expect that. Make sure that your staff is trained on this and is prepared to have this ongoing communication. So you're going to be changing your post-operative instructions, for example. You probably should provide the patient with some COVID-19 information so that they, just as an educational opportunity here to explain to them how COVID-19 works and what the most recent changes are. I did want to point something out, just kind of harking back to an earlier comment about technology. I appreciate all the wonderful new technology that's out there, but let's recognize that good old-fashioned cleaning is still the best. It's the same thing that comes out, with hand washing versus using, alcohol-based hand rubs. Good old-fashioned cleaning is better actually than using hand rubs and more thorough if it's done properly. Same thing with your ongoing cleaning is that, the technology will help, but it's not going to replace the cleaning that we should be doing on an ongoing basis, and we'll continue to do really into the future.
Thank you for that. I appreciate it. Tracey or John Trotta, do you guys have anything you'd like to add to those bullet points that we have here?
Well, we talked last time quite a bit about some of these areas of concern, but I definitely agree with John in that ASCs are poised to be very, very prominent in their community to show the practices that they have. I mean, your frontline staff is the greatest advertisement you can have, and by showing that they empathize with the patients, but that they're taking these precautions, and understanding their fears, but also having the administration or the people, running the centers to understand the employees' fears and what they are going through with this, and acknowledging, recognizing that, but setting the example, showing what needs to be done, following through this. It is something that's going to have to be really ingrained in us after, a period of time. It's going to take some time to adapt, but it really, truly does need to be something that becomes second nature to us, and just communicating what to expect on the pre-op call. This is what we're going to be doing. This is, and even putting it on your website. This is how we're taking care of you when you come here. We're poised to be a real opportunity to be able to bring in, to take up the slack from the hospitals, where they may not be able to pick up some of these cases that were being done. So there's, I think, as John has said, there's an opportunity here too. It's not just oh my goodness, we're responding and reacting to something, but an opportunity to be very proactive and really reach out to the community and help and show the roles that the ASCs play, and the fact that it is a more cost-effective and safe environment to get health care for for our, our communities and be the leader in that. So I think this truly can be an opportunity for us to shine.
I agree. And the communication and pre and post-op screening, that can all tie into technology with some maybe phone apps and things of that nature. Does anybody have any tidbits or tricks or things that they can share with the group on some best practices on how that works?
Well, as we were talking earlier, pre-op screening, a lot of the things can be done virtually, but during any contact that you have with the patient, letting them know what to expect, letting them know when they come in what to expect ahead of time with visitors. And it's going to have to start with the physician's offices a lot of times that are referring the patient. So make sure that you have a communication there and provide them with information about what is being done so they can actually start with it at that point, and the pre and post-op calling to check on them and see how they're doing, and following up to checking on exposures, as John mentioned, and knowing that you've got a plan in place that something, happen. If they ever ask you a question, your staff's got to be knowledgeable about what your process is and tell them that, to be reassuring that we're taking in all those things into consideration and have a plan for that for any eventuality. But there are scheduling programs that can be, that are suppliers that are out there that have certain capabilities to actually help you do the calls. They can do automated calls. They can do any kind of update. So there is a lot of technology available to promote and increase communication with your patients throughout this entire process. And people really need to be looking at that and taking advantage of that. Some people think it's impersonal, but right now I think it helps with the information sharing, and it reduces a lot of times phone calls to your center so that they have a place they can go on their own and check out for the information. And like I said, the use of social media and your website is incredibly important to update your information regarding your response to COVID.
Thank you. John Trotta or John Goehle?
I'm just going to jump in there on that same note about technology and apps. I'm going to use an example. I live here near the Cleveland Clinic, and they have a program called MyChart. You can actually go in there, converse with your doctors, do any kind of preliminary screening, set up virtuals. It's really an excellent way to communicate with your physician or physicians. And the response time by any physician or anyone you need to contact through that vehicle is generally well within 24 hours or greater if it's an emergency type of thing, but you don't really want to use that for emergencies. So there's definitely systems and programs out there, I think, that could be implemented. As far as technology goes with the cleaning and maintenance aspect, like John said, there is no real substitute for just really doing good old-fashioned cleaning. What we have to remember with technology is a lot of times it's geared just for efficiency and speed, and not really to be exceptionally thorough, I'll say. So sometimes it does require that, though you may have that equipment, someone may have to go through too and do some kind of hand cleaning or a little more extensive cleaning, via a staff member. So
That's a really good point. Thank you. All
And I
right.
guess
Well, go ahead.
I'm sorry, adding on to that, a lot of surgery centers, of course, there aren't that many software packages out there that are specifically geared to ASCs. And those that are stepping up. We work with a couple of the vendors out there that have really tried to add some additional functionality to their systems during this time. Unfortunately, our surgery centers don't tend to have the resources that the Cleveland Clinic would have, so they might not have that same ability there. But to John's point is, be innovative here. I think Tracey said it well. We got to start thinking outside the box and start thinking of ways to do things. I don't remember if we mentioned this the last time, but restaurants use those buzzers I don't know what you call them, but anyway, they hand you a buzzer and they, let you go outside while you're waiting for your table to be ready. Well, those things can be repurposed, certainly in the surgery center. They're already being used actually in some surgery centers to call people back from their cars or from, walking, downtown or whatever, if they're not in the surgery center, so they know when to come back to the center. So think about technology that might not be automatically built into your systems, but might be available, and certainly start using more texting. I have a brand new puppy, as just about everybody in the world knows now. And I've gotten incredible communication from my veterinarian, quite frankly, more communication from my veterinarian than I have, from our healthcare providers. So if they have that technology, we certainly can find ways to, to adapt those technologies for our use.
Yeah, my son's orthodontist is the same way. I feel like I can get communication from the orthodontist office in about every language and communication platform that is available, which is quite nice to remind me that I need to take him to his appointments. So, well, I want to thank you guys all for your wonderful expertise and insights. We'll go ahead and open it up. We have a few minutes left for some Q&A. If we don't get to your question today, or if you think of one later, you can always submit your questions to asc@intalere.com. You can unmute yourself, and I can also unmute everyone. There's also a chat box, or you can raise your hand if you have any questions. So we'll go ahead and wait a second for any questions from the audience to come in. While we're waiting, though, I do want to pose a question about N95s, which I know, John Goehle, that is your favorite topic.
Oh my Lord.
So with N95s, are fit testing for those really still required?
Yes. Yeah, I get to ask this question at least daily. Yeah, and I think people think I have a sense of humor, and I was just joking when I said you needed to do fit testing. Yes, OSHA does require you to do fit testing. So there's three things that you need if you're going to be using N95s, or if you even have N95s in your center. You need to be doing fit testing to determine which N95 you would use. You need to have a respiratory protection program in place. And that's pretty extensive, by the way. It's like having a quality improvement program or emergency preparedness program. It is quite lengthy, and you need to train people on it. And you have to do ongoing health assessments for each of the patients or each of the employees that would be wearing the N95. So if you are using N95s, you need to have all three of those elements.
All right, thank you. We're still, we don't.
To add to that, and to add on to that, Dana, too, because of any shortages and things, if they're having more than one type of N95 being used within an organization, they need to be fit tested for each type that they are using. So, and that's what made it hard. I think they kind of lifted that to some extent during the crisis, but just to be aware that is the best practice is to be fitted for those if you're having to use different ones as a substitute for a while, that they be retested with that.
Yeah, and actually, Tracey, that brings up another point, is that if you are open for doing elective procedures, there is a presumption that, first of all, you have plenty of supplies to be able to do that. So if you're going to use N95s, you need to have plenty of N95s to accommodate the procedures. But you also can't be, if you're going to be doing elective procedures, you can't be relying on some of those extraordinary measures that we allowed during the crisis, i.e. using the same mask, multiple times during the day, or re-sterilizing it. So if you're doing electives, you should not be doing any of those measures. You should be throwing out the N95 after you take it off, basically.
Oh, thank you for adding that. I was actually going to ask you about that because I heard you speaking about that, and I thought it was very interesting that those same procedures, the way you were using N95s before, if you're, assuming regular business, you need to go back to single-use N95. So thank you for adding that. So Tracey, John, do you guys have anything else you would like to add? There are no questions from the group at this time.
No.
I would just say make
All
use of the resources. If you have questions out there, there's plenty of resources available. So make use of those, and forums like this really help to see what's going on out there. because don't reinvent the wheel. Everyone's going through this. Some are at different stages right now, but there's a lot of support out there to help as you encounter different things as you're going along. So take advantage of these opportunities so that you can kind of avoid some of the pitfalls others have fallen into, and find different ways and think outside the box to perform what we normally perceive as our normal operation, but having to make some of the adaptations. So just take advantage of resources out there.
Yeah, and Intalere has a plethora of COVID resources on our emergency preparedness website on our intalere.com homepage. I posted that on the previous slide. But this recording and those links will also be made available. So, John Goehle, did you want to add anything else?
Yeah, I was just going to say, the ASC industry has been famous over the years for helping each other out, and, reach out to your friends in the industry. I love to say that I don't think there's a single policy or procedure that has ever been created in the ASC industry that hasn't been stolen from somebody else over the years, which is why we can't copyright any of them. So if you need help, reach out to your friends, reach out to your state association, reach out to me, reach out to anybody on this call. Obviously, we're all there for you. We really do want to help, and I think that's what makes us shine, is because of our willingness to help each other out.
Great, thank you. And thank you again for everyone for joining. Our next webinar will be held on Wednesday, July 8th at 1 p.m. Central. And during this time, we will be discussing supply chain topics and best practices. So I want to thank everyone for their time and have a good rest of your day.
Thank you.